We have just one action item, which is the approval of the minutes. Other than that, we have three very interesting presentations that I think will guide our thinking about what's happening, particularly around ACO development in the state and our own standard setting, as well as a initial preliminary findings of the dual diagnosis study that was mandated by the legislature. So I think we'll start. I'm going to hold off on the minutes. Chris, are you on the phone? Oh, okay. So then we can start with a quorum. So are there any changes to the minutes as presented? Hearing none, all those in favor of approving the minutes as presented? Great, thank you. So we'll move to a presentation that folks at MassHealth are going to do today on the update on the accountable care organizations that was rolled out within the year. And I'm going to, Katie will tee it up for us.
Great. So we're really fortunate to have Aditya Malingram-Degra, screw that too much, here with us today. Aditya is the Director of Performance and Strategy for the ACO and MCO programs at MassHealth. He's been at MassHealth for quite a while. He also worked on the CPR program, which was a payment reform precursor to the much larger and more extensive ACO program that was recently rolled out in March of this year. So we're excited to kind of get the 6-month update about what's been going on and what's on MassHealth's mind and what's the vision for the future. I think this ACO program is such an important contextualizing piece to all of the work that we do here at the Commission, but very specifically to the care delivery transformation work. So it's again, we're really fortunate to have Aditya. He has a couple slides, but please ask questions. We'd love this to be a conversation.
Thanks, Katie. Can everybody hear me okay? Great, well thank you everybody. I'm excited to be here to provide an update on the payment and care delivery innovation that we're doing at MassHealth. I think goals for today, I would like to go through, I've got a number of slides here as Katie mentioned, just like to go through where this program is now that we're a few months into it. In doing so, I'll also provide a little bit of the background on some of the things we were trying to achieve and show behind the curtain a little bit. And then there's a little bit at the end I'd like to talk about as we think about where we're going for the next year and some of the priorities for where to take this. So this first slide here is just an overview of the current landscape now that we've moved to this. Some of these enrollment numbers are a little bit dated, but they're largely in the same place. Since March 1st, I think most people know this, we've launched an ACO program at MassHealth and have moved a significant majority of our managed care eligible lives into that program. Very quick background on how the MassHealth program is structured. We have a number of folks who are MassHealth members, but are fee-for-service, dual eligibles, what we call third-party liability, which means they have a primary payer who's maybe a commercial carrier. We provide premium assistance or wrap supports. And then there's a large portion of the MassHealth book, which is what we call our managed care eligible population, where MassHealth is the primary payer. That population is about 1.2 million, and roughly 850,000 of those members are now in our ACOs. We have 17 ACOs, and what you'll see here when you look at the list is there are 16 of them that are health plan options for our members. So if you're a MassHealth member, you're one of these 1.2 million managed care eligible people, and you go to choose a plan, you'll actually see whichever of these 16 are available in your geography is available options for you to choose, and that's what will be on your health plan card. The 17th ACO exists within our managed care organization delivery system. So in addition to our 16 ACO options, we also still have 2 more traditional managed care organization health plans that members can enroll in. If you're in one of those, BMC or Tufts, and your primary care provider is in the Leahy system, you're attributed to the Leahy ACO, which is administered within that MCO space. So your health plan is one of the MCOs. And then we also have continuing our primary care clinician or PCC plan, which is long-standing in the MassHealth space. It's a managed care health plan option, which is run directly by the state agency. So total, historically, prior to moving to this reform, just so people have the big picture context, we had about a 2/3, 1/3 split between our old MCO program, which had 6 participating MCOs, and 1/3 of the members in the PCC plan. Now you can see we've got a significant majority in the ACO space. Most of the rest are in the MCO space, and there's actually a much smaller percentage that are in the PCC plan alone. So overall, this has been a really large shift towards capitation and value-based payment. In addition, the other thing that's worth pointing out is within our ACO options, 3 of them are partnered directly with the state, and they're doing what we call primary care ACOs, where the state is actually providing the health plan backbone and provider network. So those 3 are the ones that are listed at the bottom of the ACO list there, C3, Partners, and Steward. They're actually 3 of our largest ACOs, as you can see from the enrollment counts. So we actually still have a very large number of members who, in terms of network and who the health plan is, are working directly with the state, like our old PCC plan. It's just that most of them are now with an ACO that has total cost of care accountability, which wasn't the case before. So we're overall really excited by this. This represents, after 2-ish years of stakeholder engagement that we did with the community on the design of this program, our expectations were exceeded in terms of provider interest in participating with us and taking Medicaid risk. Every organization you see here put pen to paper on a 5-year risk contract for the Medicaid population, taking significant 2-sided cost and quality exposure because they're kind of placing a bet on themselves and a bet on us that we think we can win under this model and do well for this population. A couple other points worth pointing out while we're on this slide, so people know how our implementation went. As you might imagine, this is almost 1 million people who were effectively moved from one health plan into a different health plan all on the same day on March 1st, and we're really happy to feel now that we're a few months out from that and looking back at it that this actually went fairly smoothly. This was a really smooth and seamless transition for members, and it was something that we put a lot of effort and thought into, and that all the organizations up here and our legacy health plans worked really closely with us to make sure it was a success. Operationally, what this meant was we assigned members. We had every member had the option of choosing any of these new options that was available to them. So we noticed members well in advance of the transition and said, on March 1st, 2018, MassHealth enrollment options are changing. Here's what the ones are that are available in your area. We set up a new website, masshealthchoices.com, where members can go and they can search based on geography, search based on provider, they can pull plans up alongside each other and compare them. So we created a bunch of tools around this to support choice, but the most important thing we did is define what the right default option was for any given member. So a majority of members didn't call us to make a proactive choice because one of the things we did is we determined for the vast majority of members who had a primary care provider that was moving into one of these ACOs, we used our data systems and the data systems of our plans to figure out what the ACO was, and we put on that letter that we sent to the member, if you want to stay with your primary care provider, you're automatically going to follow them into this ACO. And we said, this is who we think your primary care provider is. If we're wrong, call us. But if this is what you want to do, you don't actually have to do anything, and this will just happen automatically. And as a result of a good amount of back-end work, it did happen automatically. We ran one big wave of this and then a smaller cleanup wave in February in the lead up to the March 1st launch, and we're pretty happy with how it turned out. We basically hit the number of members assigned into ACOs that we thought were going to be there based on early analytics. And since then, since members have had the choice to move around between options, one of the worries we had was if members are really scared about this ACO thing, or they hear bad things about it or don't like it, maybe they'll all choose to leave and we'll get 500,000 people wanting to join the PCC plan. And so far, it hasn't happened. We've had really stable enrollment levels. There's always churn in the Medicaid population. There's always people kind of moving around, but it's basically, if you look at the net inflows and outflows from these plans, they're basically all staying the same as where they were when we set them up from a market share standpoint, which is really positive. The other thing that's worth pointing out here, just because it's not obvious from the list, this geographically covers the state. Every member who's eligible for this program, regardless of where they live, has ACO and non-ACO options. Almost every member has more options under this world than they had before under our old system prior to implementing this reform, and we're pretty happy with that overall outcome. Any questions on this before I move on, or on the initial assignment and launch? Okay. So I think this is a group that knows what an ACO is, so I'm not going to do too much of the basics on this slide, but I do want to highlight a couple things that we really wanted to focus on in the MassHealth and Medicaid context. One big thing that we wanted to achieve was new partnerships. And when we did a lot of our stakeholder engagement, a lot of what we were hearing from the community is, we heard kind of two themes that felt pretty related to us. One was small providers were really afraid of big providers, and big providers didn't have a lot of trust in the capacity and capability of small providers. And we also heard that depending on what part of the delivery system you're in, you kind of look with skepticism at people in other parts of the delivery system. So we heard this from physical health about BH and LTSS and every kind of possible combination of those things. And we also, of course, heard providers complaining about payers and payers complaining about providers. And so one of the things we really wanted to achieve is new partnerships where we were able to put people under common sets of incentives rather than the kind of zero-sum kind of adversarial way in which parts of the delivery system have historically interacted. We wanted to put them under common incentives to improve care for our population. And the way in which we did that was one of our ACO models, or one key way in which we addressed it, one of our ACO models is what we call a partnership plan, and it's actually the highest uptake model. Of the 16 ACOs on the previous slide, 13 of them elected to do this model, which is a lot more than we initially expected because it's the highest financial risk of all of the models. But this is a model where a provider-led ACO system and an MCO health plan, an insurance carrier, decide that they want to go into this business together. They form a partnership that meets certain requirements, and they basically create a vertically integrated product where the provider organization has input into the decision-making of the health plan, including things like the payment incentives for providers and how they set clinical authorization criteria and what they do with the infrastructure funds. And the health plan is bringing a balance sheet, is running the claims processing and enrollment and operational backend, and together they're taking total capitation and total cost of care accountability. So this was a really exciting opportunity for us. We thought we'd maybe get a couple of takers to try something that could look like a Kaiser or a Geisinger or some of these more exciting models where you have a lot of potential for innovation in a vertically integrated space, and we had huge uptake. Almost all of our MCOs that historically participated in our MCO program found multiple provider system partners that they wanted to work with under this model, and they're taking capitation in that form today. So that's really exciting. We also had new partnerships in other forms, one example of which is C3, one of our largest ACOs, one of the primary care ACOs working directly with the state. There, I think, as folks know, a new partnership among a large number of the federally qualified health centers in the state that have come together to do a primary care community-based ACO and take on financial accountability. Sure.
Far away. Can you give an example of a capitation plan that's in force now?
Sure. So actually, on the previous slide, it's everything except those last three under the ACO bucket. So just to take the first one on the list, BMC Health Net Plan Community Alliance. This is the BMC Health Plan partnered with the Boston Medical Center Health System ACO and its affiliated primary care providers. Does that answer the question?
Could you say how much risk?
Continuing in that, you think, let's say $300 or $400 per member per month total spend. How much of that has been delegated to under the capitation? All of it?
Sure. So more or less all of it, and let me define more specifically what I mean by that. We have, even for our managed care eligible members, there's a portion of MassHealth covered services which we have not historically and have not yet under this reform put under capitated risk in our managed care space. So the easiest way to think about this is it's our most of our long-term services and supports, things like PCA, adult foster care, group adult foster care, those kinds of benefits. Those things are paid fee-for-service by the state. Those are continuing in that vein, although we have talked about, and it is in our waiver plan, to think about opportunities to pull that under capitation in the future. So outside of that, which would include physical health, behavioral health, pharmacy, all of those kinds of services, hospital, professional, they're all part of the capitation.
And then how much does BMC take from us?
What is the capitated rate?
It varies a little bit between rating categories and plans. I would say you're in the ballpark with 400 PMPM of probably what it mixes out to across everything. But for example, we do a number of things in our rate construct where we pay different rates for like a child without disabilities versus an adult with disabilities. They're all kind of rated separately and then risk adjusted. So each of these plans is going to have a different average rate depending on their mix of those various things. And there's a decent amount of variation. So a good example of that would be the Tufts Children's ACO, since it's all children, has a pretty different risk profile and overall cost than the Fallon Berkshire ACOs. The capitation rates for those ACOs are different on average, but they're based on the same statewide rating construct. And then, Katie, to answer your question, could you just say a little? I want to make sure I'm answering
The
exactly what you're
question
asking.
is one that I thought Dr. Kreider was going to, but he kind of stopped short of it, which is how much risk is moving from the MCO, who is taking that capitated PMPM, through to the ACO. And I think we've learned some of this through ACO certification that there's a great degree of variability, but could you speak to that?
Sure. It's a somewhat unsatisfying answer. The answer is it varies among these various relationships. So we do have a contractual requirement that kind of sets a minimum and kind of gives a push in the right direction, but these organizations and partnerships have all taken slightly different approaches. What we've required is that there be at least, the risk basically amount to at least 5% of the medical capitation. And there are partnerships where that's what they did for year one, and then it kind of floats up to more like 50-50 by the end of the program. There are partnerships that are more used to doing financial risk arrangements together where they started out 50-50. It gets a little complicated because there's also the DSRIP funding stream, and then in addition to medical capitation, there's the non-medical portion of capitation, which is where we put our admin payments. They've all kind of done slightly different things, and you can kind of arbitrage between these different buckets of funding. So for some of them, it's, the ACO gets all the DSRIP, and the health plan gets all the admin, and the medical capitation is what's at some kind of shared risk. For others, it's kind of all one pool. It varies slightly. I would say general themes are the provider organizations are at some pretty meaningful non-zero risk pretty much right away, and in most cases it scales up as the program goes along. For the most part, they're making joint decisions about DSRIP and admin, but I would say in general the ACOs are more in the driver's seat around DSRIP, and the MCOs are more in the driver's seat around admin. Okay, so so I was talking a little bit about some of the key themes that we wanted to emphasize in the Medicaid space, one of which was new partnerships. Another, which I've alluded to a little bit, is integrating these silos that we observe between physical health, behavioral health, long-term services, and to some extent social services as well. There are a few ways in which we did this, the most important of which I think is the Community Partners Program, which we'll talk a little bit about in a couple, I think on the next slide. But there's other things that we're doing as well. So our quality measure slate, for example, starts to have measures that are around integration. When we do member satisfaction surveys, we are going to be separately surveying for behavioral health and LTSS specific things in addition to a more traditional primary care focused survey. We're sharing member level LTSS utilization data with our ACOs as part of the data reporting we do with them, which is kind of feels like a small thing, but it's actually an important new development because they're now able to look at, okay, I've got this complex member who I'm not able to find to engage my care management program, but hey, someone is actually going out to their house every whatever weeks to do an LTSS benefit, and I can see what provider that is. So I can just call them and we can try and figure some of these things out. There's obviously more complexity to it than that, but it's the kind of thing that's enabling greater awareness of what's happening in other parts of the delivery system and better coordination, which is really beneficial for this population.
If we could just spend a minute, I think that's a huge innovation and should not be undersold. I think, I'd love for you to spend a minute on some of the innovation of sharing other health and human services data about the ACO population with, I know it's really complicated, but just spend a minute on kind of your efforts there.
Sure, I could probably do a minute and then I'll get out of my depth really quickly. So happy to take this one back and provide more offline if people are interested. There's a few things we've done in this space, and our ACOs have asked us to do more. So I know it's one of the things that's on our priority list for enhancements to our data reporting going forward. One is that the member level data that we share as part of our reports does have certain flags on it for involvement of other state agencies, and we started to look at sharing, kind of two-way sharing of contact information for some of the, for example, like some of the DDS services and ACO care managers, so that there can be better enabled coordination between various efforts. And ACOs have been really interested in seeing more of those interagency flags in the data, so that because they find it really relevant to some of the work. Another is in standing up our community partners program, and I'm sorry, I'm not familiar with the details here, but I know there was a large amount of work, both actually with CMS on the Medicare and dual side and across our agencies to pool data so that we were able to correctly identify the community partners population, because their eligibility and assignment algorithm incorporates elements of those things. So for example, involvement in certain other agency programs would be duplicative with the community partners benefit, so those members are not part of the community partners assignment pool. On the flip side, members that are in what we now call ACCS, some of whom are dual eligible with Medicare, are part of what now gets handled by the community partner system. So we wanted to make sure we were capturing that data and identifying that population appropriately. So that's a little bit of hand wavy on, like, there's definitely a good amount of stuff happening there. I think we can follow up and help provide more specifics. Okay, so the integration is another big piece. I mentioned social services, which is a place that we are pretty early in the overall life cycle on, but I think eager to push the envelope. There's a few things happening here. One is that ACOs and MCOs are required under their contracts, and we made them submit these screenings to us for approval in advance. They're required to screen members for social service needs and for health-related social needs. So these are screenings that are happening either as part of what you might know as like a health risk assessment that a health plan would send out to people, or that are happening in primary care offices. There's a number of ways in which they're doing this. They're integrating it with tools that they use for assessment and care planning in their complex care management programs, and our community partners are doing it as part of their engagement with members. So it's kind of happening in a number of places, but we've been trying to place a much stronger emphasis on ACOs trying to understand this data about their members, trying to collect it, incorporate it into medical records, and then ideally start doing something with it. On our end, we are leveraging what limited data we have about social need in our administrative data to enhance our risk adjustment, which is something we're pretty excited about. So starting with the first rating year of the ACO program, we incorporated a number of, we basically ran a project to build an enhanced total cost of care risk adjustment model that added administratively derived variables about social risk. And so these were things like looking at how many times in a certain period did a member's address change, which might indicate housing instability, or looking at, does a member actually have a diagnosis of homelessness, which is something that we could pull in, or looking at even things like the geography in which the member lives. When we pull in census tract level data, what does it tell us about the potential social risk of members who live in that geography on average? None of these are, I would say, especially individually, particularly great data sources or particularly actionable at a member level. But we found when we worked with colleagues at UMass to run a whole bunch of analytics at a population level is they actually are explanatory on total cost of care risk. And so when we incorporated them into our risk adjuster, we got both a better risk adjustment model in general, which is just good for everybody, and we got a risk adjustment model that puts more money at populations that have higher social risk, all other things being equal, which is exactly the kind of thing we want to incentivize. Because if there's two populations that are exactly the same, but one has more social risk associated with it and therefore is likely to have higher costs, we want that ACO to have a higher capitation. We want to direct resources towards addressing the needs of that population. And so the first time we're actually doing that in a kind of systematized way. And then there's, of course, our flexible services program, which I'll speak a little bit to later in the presentation. We recently got authority from CMS to move forward with this part of our waiver. We asked for flexible services authority at the beginning of the program design, and this is basically a pool of funds that ACOs can use to address certain health-related social needs. So we'll be working with our ACOs to flesh out exactly what that program looks like and stand it up over the coming year, but that's something we're pretty excited to finally be getting going on. Another key priority for us is you can imagine a Medicaid ACO program being kind of a watered down version of like a Medicare or commercial ACO program. It was really important to us that that not be the case. We wanted to go, this is not a state where Medicaid is the first actor on ACO activity, as is the case in some other states that have done Medicaid ACOs. This is a state where we've got provider systems that have been doing risk-based contracting for a while, are pretty sophisticated and good at this stuff. We wanted to bring the full benefits of that to the Medicaid population. So there is no ACO in this program that is not taking two-sided risk. There's pretty significant financial dollars behind this. Really meaningful first dollar incentives, high marginal incentives around doing a good job for this population. A big chunk of success in this program is based on quality and member experience. And we think we push the envelope pretty hard. Even in some cases, we think doing things that are more advanced than what we're seeing in some commercial and Medicare spaces, because we wanted these ACOs when they're, and I know HPC thinks about this a lot, that there's kind of operating structures that are more payer specific or contract specific, but they do roll up into these kind of more macro organizations that oversee these portfolios. We did not want the Medicaid portion of the business to be a secondary or tertiary concern. We wanted to be pretty front and center when they think about success. So we think we've done that pretty successfully. So with that, I'm going to move through the rest of these a little bit quicker, but wanted to lay some groundwork.
7 minutes just to take
Thank you. So I want to talk a little bit about community partners. I've already mentioned a little bit. This is something that really came from our stakeholder engagement on the front. So I mentioned what we heard about the silos of care. We also heard a lot from community-based organizations that, and we're really fortunate in Massachusetts to have a lot of these, have demonstrated expertise in engaging certain parts of the Medicaid population, especially members with complex BH needs or dual diagnosis needs, and members with disabilities or who otherwise require community supports to live in the community. And these organizations really wanted to have a seat at the table and a role in this new space. But they also recognized that they probably needed to evolve and change as part of making that happen. And that was really what we attempted to do with the Community Partners Program. We did a state-run procurement and contracting effort where we now are contracted with 27 of these community-based groups. In a lot of cases, they're actually consortia of what were previously individual groups. There's one key way in which they're evolving in order to do this. They're investing in capacity and economies of scale and shared infrastructure. And then what we did is we required that all of our ACOs and MCOs have to work with the community partners in their geographies. They actually have to sit down, execute contracts, and figure out how they're going to coordinate together on the management of member care. We define parameters for it. There's a care model that goes along with it. There's specific process things. But the core of this was that nobody gets to play and nobody gets access to the district infrastructure dollars unless you've done this. You have to sit across the table with the community organizations and figure out how you're going to leverage each other's expertise. Early example, and another key thing to call out here is this community partners program is really about care coordination and management and member engagement rather than actual service delivery. So the service delivery piece is still happening. It's a little confusing because a lot of times these are the same organizations, meaning that these are also providers that have contracts with us or the plans. But in their capacity as community partners, what they're doing is helping the ACOs to engage this particular population, which could mean going out to their homes or finding them in the community, get these members bought in and participating in care management or care coordination efforts, and serving as a subject matter expert and technical resource to the ACOs to make sure that they're approaching this population appropriately and not over-medicalizing the model of care for them. A couple quick early examples from this program. This launched in July, by the way. We went live with community partners, so it's a little fresher than the program as a whole. But just so you get these really help me get a feel for like what are they actually doing. One is on the LTSS community partner side. We had a care navigator figure out that a member, they were on a particular federal benefits program that was helping them maintain temporary housing, which they were about to lose. And this navigator, first of all, figured out that this was going on, helped this member get transportation so that they could go and sign time-dependent paperwork, which ended up allowing them to get into an apartment complex that they'd been on a waiting list for and just kind of opened up. They didn't have transportation, so they weren't going to be able to get out there, but because somebody was sort of working with them in this capacity, it all kind of came together. Another example, which is a little more related to medical management, is on the behavioral health side. We had a care coordinator go out to somebody's home to engage them in care. And while they were there, they were kind of asking this member questions about their plan of care. And the member brought out basically a suitcase, opened it up, and it's full of medications that are not really organized in any particular way. And the member didn't really know what half of them were or what to do with them. And because the community partner had actually gone to this member's home and engaged with them in this way, they discovered this issue. And then they were able to and empowered to bring in the right set of providers and coordinate to figure out, what's going on and how can we help this member have a more coherent plan of care that we're actually educating them on. So these are the kinds of things. When I think about what they do, the sort of one-line version is these are the members who previously fell through the cracks when it comes to doing care management for the Medicaid population. And they often have significant issues, a lot of them social, that are undiscovered unless you go out and meet them where they live or where they hang out. And that's what community partners do. They have the expertise for it, they can build the relationships. And the way that they need to kind of evolve is they now need to build the expertise to work with the rest of the medical system so that they can kind of come together and meet in the middle so that these members don't fall through the cracks anymore.
What's the payment structure for the community partners?
The payment structure is they get an infrastructure payment, and they basically, most of their funds are a PMPM, which is paid by the state. But it's paid contingent on certain criteria and activities being met, which often require a sign-off on the ACO side. So there has to be some dual action in order for the payment to get triggered.
Is the payment risk adjusted?
The payment is not risk adjusted, but they also have a quality program on top of this, and we're hoping to get data through that about more about what the population looks like. Payment is based on what we believe is appropriate PMPM for these administrative supports for this population. And I wish I had the numbers off the top of my head, but it's like a fairly substantial PMPM.
I wonder if it's also worth showing the DSRIP investment for the CPs, which is on a later slide, because that's a significant infrastructure investment.
Yeah, that's the pool of funds it's all coming from. Yeah. So this I'll just touch on very briefly. Member supports is a really important part of this program. This is a member-facing ACO program. So we could have gone, when I say we could have done a watered-down ACO, we could have said, MassHealth members want to understand what an ACO is. We're going to do this whole thing on the back end. We'll do retrospective TCOC with these organizations, and we don't need to really tell anybody they're in an ACO. That's not what we did. The ACO's on their health plan card. If they've got a problem, they call their ACO's customer service. Every ACO has a grievance line the member can call. And we wanted this to be something members understand what it is. They can vote with their feet and leave their ACO anytime in their plan selection period. They'll take their DSRIP dollars with them because the amount of infrastructure funding an ACO gets is based on their population. And we wanted this to be something where there's real accountability to the actual member. So the ombudsman support is just one example of the ways in which we're trying to provide support from our end to our member population to make them informed and empowered as they engage with this model.
How many applicants are voting with their feet? Among the ACOs, how much does churn, are you measuring how much churn varies? I mean, managing clinical risk is impossible if you only have responsibility for somebody for 6 months. Are you measuring churn for each individual ACO, and how much does it vary?
It's a great question. So in case people couldn't hear, the question was, are we measuring churn? The answer is yes. I actually did have a version of slide 7 that had the number, and I don't remember it off the top of my head. It's single digits percent is what we've seen in terms of movement across these plans. Like I said, it's actually netted out to be fairly stable. Part of it is just endemic enrollment churn, meaning people move between MassHealth and the connector, for example. So that we can't really do a lot about. Within the population of MassHealth eligible people, we have actually instituted a fixed enrollment policy. It's been fairly relaxed this year because we've been prioritizing making sure members feel that they've landed in the right ACO after all of that reform work. But we do, as a baseline, have a policy that after enrolling in a plan, members have basically 3 months to move around or choose a different plan. And then after that, they move into what we call fixed enrollment for the remainder of the year, so basically for another 9 months. And that's a new policy that we started doing in 2016, in part in response to feedback like that, which is we wanted to create longer-term incentives for managing member care. So let me just move to the last slide here. Just skimming through these really quick. There's a number of quality measures that ACOs and CPs are accountable for, many of which include actual integration, as I mentioned. And in addition to our ACOs and community partners, there are a number of statewide enabling efforts we're doing, largely around workforce, to help support this initiative and make it work. These are all also funded by the DSRIP funds and our waiver program. Slide 14 has a couple of examples of cool things that ACOs are doing with DSRIP investments, as well as an aggregate breakdown of how it plays out. You can see at the top right of the page, there's innovative programs around how to engage members and get them involved in care management and communicating with their providers, as well as expanding programs that are, we have programs in the state that are best in class, demonstrated success in Medicare and commercial ACOs that were previously not available to Medicaid members. These funds are allowing those things to now move into the Medicaid space. So I just want to spend like 1 minute on slide 15, and then I think I'm done. So, so this is where we are now. We're a few months into this. We feel really good about the overall launch, and I hope this has been helpful and give you some context to what we're trying to do. As we think about what's working the way we expected it to versus what has room for improvement and what we want to spend time on next year, these are some of the key priorities. We talked about the Community Partners Program. I would say on the plus side, when you take those 27 community partners and the 17 ACOs and you do this, that's over 200 relationships that had to come together in order for this program to get off the ground. That actually happened. So in the midst of all this other work, they actually all did do this. They sat across the table, figured out a lot of the basics of how they wanted to work together, and successfully got there for this program to launch on July 1, which is huge. We also have, to the examples I gave, there's now this huge number of feet on the street trying to find members that are identified for this program and engage them, because that's the only way community partners can get paid. So we've created an incentive and a workforce and infrastructure behind that didn't previously exist. So we're finding unmet social need, we're finding people who weren't previously talking to primary care or going to primary care, and people are actually going and meeting them now, which is really important. Some things are not working all that well. And you can imagine what happens when you take organizations from very different cultures, you make them form 200 relationships on a short timeline, and they have to go do a bunch of work together. There's some friction there and things that they will need to work out in order for this to improve. And there's things that we as the state, I think, have to do a better job of in defining roles and responsibilities a little more clearly, as well as performance expectations. So this is a key focus of ours for the next year. It's really important to us that this partnership is something that both sides believe is working and are bought into the future success of. Because when the district funds go away, the only way they're actually going to stay together is if they see value in that partnership, which is really the vision. Flexible services, as I mentioned, we got authority for this. Now we have to actually design what this program looks like and get it off the ground. You can expect that to be something we're doing a decent amount of policy work and operational work on our end over the next year, as well as engaging directly with our ACOs about what they want to do in this space. Data and reporting, I've mentioned in passing a couple of times. This is actually core to ACOs being able to succeed. They need to understand how their total cost of care is looking. At any given time, they need to project performance. They need to have the right supports from us to be able to do analytics and care management. It's particularly important for the primary care ACOs, those three that I mentioned, because they're relying on MassHealth as the plan. So we're really focused on improving data and reporting as a whole. I think we've learned a lot from our first year of trying to provide more robust data supports. But in particular, the primary care ACOs, as we've been talking with them and thinking about how to make that model most successful, we've recognized that we probably need to evolve a little bit as a payer. We can't just kind of run this the way we've always run fee-for-service. We have to think about ourselves as a business partner to ACOs that hold cost of care risk and start thinking about what that means. And we can actually learn from our MCOs that are doing the partnership plans in doing that. So those are some of the places we want to put effort. I would be remiss if I didn't mention this is additive stuff off of a huge amount of base work that we're going to continue, which is what allows us to feel good that this program is doing all the core things it needs to. Providers are getting paid, members are getting medically necessary care, they're having a good experience, all of our regulations and rules are being followed. That's a really large amount of what we've spent this year doing, and we'll continue that into next year as well.
Thank you. Just a couple observations. And first, congratulations on it's not a full year, but I think a very impressive rollout of this. I work with lots of community organizations that work with MassHealth patients, and come last March, I was expecting to hear more about folks being confused, not knowing what's happening with their health plan. Heard very little of that, and so kudos to MassHealth for pulling that off. I'm sure there were some cases, but generally I think people were very impressed with the rollout. I think the outreach and engagement through the community partners is a significant addition to what to how we think about care for MassHealth patients and great success. And the other piece of that I think is important is in some ways you have fundamentally changed the provider system, moving from what has been a competitive environment to a collaborative environment, and that's I think a significant change that can only improve care moving forward. I also think using the data from other state agencies and sort of as an overlay to the MassHealth population is something that has been long overdue in the state. So congratulations as well. I just one thing to think about. I think that when you mentioned the screening for behavioral health and social services that's happening now, that is great data that we should be thinking about how to use that for system-wide improvements. And so as you get more experience with that, and sort of we should be thinking about how do we use that data to think about. All right, thank you.
Great, thank you, Aditya. So I'm going to ask Catherine and Courtney to come on up. We'll try to get through these next two portions in 20 minutes so that we can get everyone out in time and finish. So to just orient ourselves. So since our last committee meeting in September, our team has continued to engage a wide variety of stakeholders about our draft plan for ACO Certification 2.0 standards for 2019. We've gotten a lot of really great feedback that has led us to reflect on our path and also the public policy value of this program. And so we've done a lot of reflective thinking and are coming here today with a slightly different proposal than the one that we came here with in September. It is in line with all the values and importance of this program that we talked about before. But I think, being responsive to stakeholder feedback and trying to balance the public policy value with the administrative request that this program does demand of providers is an important consideration. So Catherine and Courtney will take us through. Please stop us and ask questions. We're really eager for your feedback. The next step in the process, just to orient you all, is to put this out for public comment and have a much broader, more formal stakeholder feedback process, and then come back to the board in the early new year to finalize the standards determination.
So Commissioners, so of course we always find it valuable to start off this kind of conversation with a reminder about our vision and our values for what we're trying to accomplish. I would say the hallmarks of our vision for a transformed care delivery system are accountability, high value, patient-centeredness, and integration of care across the spectrum of needs. And really the primary aim of our ACO certification program is to help advance that vision. Obviously, we're also trying to be mindful of and reflect a balance of different interests, including, as Katie just mentioned, the sort of potentially competing aims of public transparency on the one hand and provider burden on the other. So also, Commissioners, as we've spoken about a number of times before, the initial aims of our ACO certification program, as it was launched in 2017, were really to create multi-payer standards for ACOs, to build a knowledge base and enable greater learning, and to align with other standards that are already in the market, such as MassHealth's Medicare program and commercial ACOs as well. But we've also said from the outset that our longer-term vision for this program is that we move away from a process-based certification and instead evaluate ACOs for certification based on actual cost and quality performance. And I think that's really important to keep in mind. In fact, our statutory requirement, directs us to be considering developing a model ACO program in the future. So we have that at the top of our minds now as well. So as Katie alluded to, we've had a number of conversations with stakeholders over the past couple of months since we were before the committee in October. And I do want to take this opportunity to really earnestly thank the organizations that we've spoken with. They reviewed our stuff in advance, they met with us, they shared really thoughtful and candid and honest feedback, and it really makes a difference. So I just want to note that without that kind of partnership, I don't think we would be able to be evolving our program as effectively as we are. So I do want to say thank you. In terms of the kinds and the themes of stakeholder engagement, it's hard to do justice on it in just one slide. But I'll try to hit some of the highlights in the themes that we heard. On the whole, I think I would say we heard some validating things about the program, that stakeholders really understand what we're trying to accomplish with certification, and that generally our standards make sense, that we're hitting on the right things. That said, I think we were really also challenged to think rigorously about the purpose and goals of ACO certification. We've said that we are both interested in advancing the evidence base and developing a greater evidence base on ACOs, as well as continue to sort of push the market and use certification to advance certain policy priorities and ideals. And some of the stakeholders expressed that their view is that the program would really be more meaningful if we focus in that area of evidence generation and really focus the program on that aim in particular. And I think that feedback really underscored a point that we've been aware of all along, that as long as we're stuck in a place where we're trying to evaluate ACOs based on process, that's quite limiting, especially in an environment where there's such great variety in ACO structures and operations and how they approach various care delivery aspects. So I would say that sort of constellation of points really hit home during these last couple of months of stakeholder engagement. We also heard a general caution from ACOs about changing our requirements too quickly, and an argument that it might be better to keep our standards more or less consistent so that we could look at a little bit of change over time on consistent measures. And again, the theme of administrative burden was clear, and a cry for simplification and reduction of burden as much as possible. And finally, from some of the other types of organizations that we spoke with, particularly those that are focused on representing patients and communities, We heard a lot of interest in certification being a tool to continue to encourage increased collaboration between the healthcare system and other types of actors like social service agencies, and really continue to push for that greater integration of physical, behavioral, oral health, social needs, et cetera. So I think these conversations in a nutshell really have had an impact on us. And I'm going to let Courtney take over here to take you through the revised proposal for 2019.
I just want to make one quick nod to the integration of medical, behavioral, and social. Obviously, we just heard all the amazing work that MassHealth is doing to support those kinds of relationships. I think what we saw in certification and what we've heard in these conversations is that doesn't necessarily carry through with commercial and Medicare. And so what is the utility of the ACO certification program as an all-payer, all-patient certification program to continue to promote the goals that MassHealth is trying to promote through their reform in a way that makes sense for those other populations, obviously. Sorry, go ahead, Karen.
Okay. So taking all this feedback into account, the ACO certification team has developed a new proposal for the 2019 criteria that's different from what we proposed in our October meeting. We're still proposing to have 3 major sections of the application: background information, assessment criteria, and supplemental information. The key difference in this new plan that we're proposing is to not change the assessment criteria significantly from our 2017 standards. We'll get into that in the next few slides, but I do quickly want to mention we're also proposing to develop an optional distinction program, which is intended to be in addition to ACO certification, and we'll look at specific aspects of the ACO performance, and Catherine will get into that. So I'll go through this quickly for the sake of time, but the background information section has not changed significantly since our last meeting. There'll be 3 sections: a summary of the applicant organization, where the ACOs will have to provide descriptions of their organization, its history, and its mission, and also describe what regions in Massachusetts they are operating in. They will also have to submit a list of primary care practices and hospitals that participate in the ACO. And we'll note any differences between providers for each risk contracts. And we will work with the RPO team so that ACOs will only have to submit this information if it is not apparently linked to submission from the Massachusetts Registration of Provider Organization data. And then finally, we're asking ACOs to submit information about their risk contracts, including details about the individual risk contracts, such as who the payers are that the contracts are with, and financial terms. And we're also asking the ACOs to report their final ACO level quality data. So our proposed approach for the 2019 criteria section has changed, as I mentioned. As a reminder, this particular section is a portion of the application where the HPC defines certain standards and applicants have to submit documentation to meet the standards. Many stakeholders expressed concerns, as Catherine was describing, about us changing our standards too quickly, and that may potentially outpace, our standards may outpace the rate at which ACOs are able to implement changes in the organization. So understanding this, we recommend keeping almost all of the 2017 criteria as they are, with a few exceptions. Certain items will be relocated to the background information section, including the quality-based risk contract information I just described, and also an organizational chart that previously was submitted in the governance structure criteria. For the 2019 application, ACOs that are reapplying for certification will have to update their 2017 responses with current information. But in cases where no changes have occurred, ACOs may attest that their response from 2017 reflect current operations and that they're still fully accurate and applicable. So then, for the supplemental information section, the questions will remain, or this section will remain the section that addresses topics relevant to accountable care, but where we see that there isn't enough evidence base to support a standard. We're proposing to structure the supplemental information question section differently than last year, where we'll have 2 distinct sections that address complementary goals of the program and may help us inform future standards in this model ACO development Catherine mentioned earlier. So the first section, adding to the evidence base, seeks to add to or fill known evidence gaps in the literature. So current topics may include distribution of shared savings, methodology, providing high-value care, strategies for integrating behavioral health into primary care, and how ACOs use health information technology to facilitate care coordination.
One other kind of late-breaking one that we've been thinking about, and it was a hot topic of conversation in the committee meeting prior to this one, is asking about their voting behavior. I think one other topic that came up in Mode was sort of where the ACO is versus the corporate entity, and I think that's come up time and time again with how we define this program and how we define ACO standards versus the corporate entity writ large, because the ACO is a much narrower contracting legal entity than the whole organization. So I think that's one other idea that we could ask about. I know Dr. Kreider, you're very interested in staff associated with coding, but you know, I think we're interested in what do they see as the strategic value in coding? Is it just sort of financial incentives, or is there something on data and reporting, or something more potentially care delivery positive? For coding, it's to hear directly from ACOs around that is another idea that we've had.
So the second section, emerging topics, will explore ACO strategies and approaches to providing integrated patient-centered care. This section provides an opportunity to hear more about ACO innovations in new and emerging areas that may be instructive to the market overall. Some proposed topics that we're thinking about including our workforce, innovative care models, and a strategic focus on the social determinants of health. So, any questions before we move on to the distinction program?
Great, so that's really our core proposal for the 2019 program. That's all that would be required, you know, that background information section, the assessment criteria with attestations as appropriate, responses to the supplemental information questions. Now, on top of that, and really also I think as a result of our recent stakeholder conversations, we've kind of pushed ourselves and challenged ourselves to reconsider whether there might in fact be a way for us to begin looking at actual, evaluating ACOs based on actual performance, and to start to craft a program that would recognize ACOs based on cost and quality outcomes rather than just process or structural standards. So we've come up with an idea that really is still in the early stages of development, but that we would really like to focus on in the coming months and hopefully be able to launch in a year or so. And that is to create an add-on to the basic certification program that we're sort of calling Distinction for ACOs, that would recognize ACOs that have achieved improvement in their performance on measures in each of the domains of the triple aim. So that's, you know, better health outcomes, better care, and lower cost, and in measures of health equity. And to also make a commitment to continuing to improve in those areas. So more specifically, here's a bit of what we're thinking about in terms of the actual requirements for this distinction program. We're thinking that there would be two main elements. The first would be a performance reporting element, where we would require ACOs to report data to us, demonstrating that they've improved performance on 3 specific measures in each of those areas: cost, access to care, and quality outcomes. We're thinking that the HPC would select a cost measure like total medical expenditure, total cost of care, and an access measure such as pediatric well visits or ED utilization. And as far as the quality outcomes domain, that we allow ACOs to select from the aligned measure set, one of the 5 core measures that are in that set. With regard to health equity, we're thinking that we would ask the ACOs to report its performance data on one of those 3 measures that I was just talking about as stratified by a social determinant of health, you know, like for example, by race, and show that its improvement was actually helping to close those health inequities or close disparities. So that's kind of the first performance reporting element. The second piece of the distinction requirements would be a strategic planning element. So we'd have ACOs submit a strategic plan to us indicating how they plan to continue improving their performance going forward.
Kind of reconcile what the peers are including. So thinking about the cost metric, what peers are including their contracts versus how HPC, for example, would look at whether this ACO has I guess, have you given thought to how you would reconcile to make sure it's consistent with that these metrics are consistent with what is in the.
That's a great question. I think we have a lot of thinking and work to do on exactly how we would measure total medical expense and total cost of care. One of the limitations I think we might face here is in order to make the distinction determination on some kind of relatively timely basis, we might be depending on ACO internal data rather than reconciled payer data that might take a year or more to be adjudicated. So I think we've got, the short answer is we've got a lot of thinking to do. Katie, if you have any.
Yeah, it's a really good question, Lauren, and one that we've started to think about, but exactly as Catherine said, I think we have more work to do here and would really be interested in feedback from stakeholders. This idea of aggregating total cost of care performance across an applicant ACO, which may have multiple Medicaid, Medicare, which all have different financial models and different financial benchmarks, as you know. We have seen in some data that we've collected through ACO certification and working with our colleagues who do the PIPS process and some other data collection activities here. Systems do tend to look at total medical expenditure across commercial, across Medicare, across Medicaid for their risk lives. So I think we feel confident that that's something that they could share with us. Many other questions about timing of that and what would the rate of improvement have to be to seek distinction? Would we be looking? I mean, I think all we could do is really look at them versus themselves over time. So over a consistent 2-year time period, did you improve a total cost of care or total medical expenditure? But that might not be the right measure, as Catherine said. Maybe we need a proxy for costs like readmissions or EDUs or something like that. I don't think we have a solid grasp on that yet.
So just to try to put a few more meat on the bones here, as Katie was just saying, I think we're thinking about awarding distinction at the applicant level. So just at the same level of the organization that would be seeking certification, thinking distinction would be effective for 2 or 3 years. And another element of the performance reporting piece, in addition to sort of giving us this data over the past 2 years of performance, internal data, we'd be looking for ACOs to tell us something about how they think they achieved those improvements, what strategies they had in place, and we would hope to use that information to start to tie together some of this process stuff with the outcomes, and maybe over time start to work on this model ACO concept. And on the strategic planning aspect, I think one of the questions we're thinking about now is what would be the appropriate measures to include, and whether that would be something the HPC would continue to select and sort of standardize across our ACO cohort versus giving ACOs the chance to select their own measures. If I may, my area of focus for next year is going to be diabetes, and here's my strategic plan to try to improve. And then we would, expect to reevaluate them for distinction based on their strategic plans at the end of the 2 or 3 year distinction term. So that's where we are today in our thinking. I just want to make 2 more really fairly quick points, and then would love to hear additional conversation and feedback on this. First is I want to acknowledge, as we've really said before, that when we came before the committee in October, before we really embarked on our stakeholder engagement work, we had a pretty different proposal for 2019. So as a reminder, most importantly, we were talking about updating our assessment criteria and putting a lot of attention and focus there. And today we're in a different place. And I think more of our energy now is looking forward toward building, this goal of building the evidence base and moving toward a more performance-based system for evaluating ACOs. So it's worth being clear that there are trade-offs between what we're proposing today versus what you saw in October. I think under our original proposal, it really would have prioritized that goal of raising the bar, improving on last year's standards a bit, clarifying some things. But that said, I think the original proposal also would have kind of more maintained this focus on process-based standards, and probably would not have really addressed much of the concern from the provider community about burden. In contrast, I think what we're now thinking about in terms of keeping the assessment criteria the same and really working toward this distinction program, it has some advantages. We wouldn't necessarily be setting a higher bar right out of the gate, but we would arguably be making better use of our supplemental questions to get more targeted information, both about filling the evidence gaps and helping highlight new and innovative approaches that ACOs are taking. And most importantly, I think our revised proposal helps us focus more resources on developing the methods for evaluating ACOs based on performance, which we know is where we want to go in the future, as well as being a bit more responsive to the concern about burden. So that's where we are today. We look forward to your feedback today, and next steps are really to develop a public comment document, put that out hopefully before the holidays, possibly have a public hearing to discuss that further in January, and then we'll have to hit the ground running late this winter and early spring to operationalize this so that ACOs can begin going through the process of certification over the summer and fall.
Comments, Chris? Any comments?
Yeah, one comment, Marty. I think it's great to hear. It is obviously critically important to move from process measures to outcome measures. And I don't think it's too soon to be thinking about real clinical measures necessary, which are necessary antecedents to a reduction of costs. And we can look at ER visits and what we say we do look at ER visits and pediatric well visits and stuff like that. But we're entering an era right now pretty fast. Population health programs include remote monitoring. So I would think real clinical measures like blood pressure, weight, and glucose, the things that we know if we see improvements in those things, the population can have enormous implications for reduction in cost and improvement of health. So I don't think it's too soon to be contemplating how you can be working with the ACOs to determine how they're deploying remote monitoring, when and how, and how often they're collecting this data. That's the sort of stuff that we will hope the HPC will be able to push to understand better the actually define performance, what's called distinction required performance reporting. So, that's it. That's my own thought. Another thought.
Great, thank you. Okay, so I just want to restate my support and applaud the efforts to go back and really take in the stakeholder feedback to rethink the criteria and being sensitive to the calls for administrative simplification. So I applaud that. I also am supportive of the goals of the distinction program, and this might be stating the obvious, but I think we just need to caution about the way that we are measuring and evaluating whether an ACO meets that distinction criteria should be apples to apples comparison, so that we're not allowing the ACOs to pick which metric they want to be measured on, but it's the determining whether they fall into that distinction program. So, but support the underlying goals, but I just think we'll take careful thought to make sure that we do it right and we're not creating an arbitrary seal of approval.
So I agree with Chris that, ultimately we want to move from process measures to evaluating performance. That's key. What I'm struggling with, and I agree with Lauren that we should watch out about cherry picking here, because there may be a tendency to just pick measures where I know I might be more successful than others. I want to go back though, this is a voluntary program. The ACOs we have are here because they were required to have HPC certification as part of their MassHealth contract. I'm wondering, did we reach out to any of the non-MassHealth ACOs to see why they haven't voluntarily sought certification as an ACO? And does that tell us something about the market and our standards? And is there something there that we should be thinking about for that part of our certification that would bring that pool into our work? And then on the distinction piece, I had this conversation with Katie. I'm a little worried that we might create a distinction and nobody will come to the party. I think there are a couple that will because that's how they're organized and that's how they're thinking. But I worry a little bit that the focus will be on improvement within the distinction groups, but the rest, the majority sort of stay behind. And what does that mean for our work in terms of trying to raise the bar? So just a couple thoughts.
Yeah. So a couple reactions. On the question about non-MassHealth ACOs, we haven't talked to that kind of handful, that group too much recently, but I will say that in our current pool, we actually do have an applicant for certification that is not a MassHealth ACO. They've submitted their materials and we're considering them right now for certification. So that, doesn't sort of totally address the point, but I think it may be an indication that once a standard is set, once there's a program out there, it may take some time, but there may be people who, start to say, okay, maybe I want to go ahead and do that. And maybe I think, the stakeholder feedback we did get about our standards is that more or less these are the right topics. These are the applicable things. So I have some faith that we're on the right track in terms of our baseline criteria here. On the question about the distinction program, sort of throwing a party and no one comes, I think that's a possibility, and I also would hope that even if we don't get a ton of comers, we will learn something from having done it, and those that have applied we'll learn from them, and potentially over time we sort of exit the program that's based on process, and we really institute a certification program that's all based on quality and cost performance, and hopefully MassHealth and other payers would potentially take that up and evolve with us in that direction.
Yeah, I think that's the real goal. I think as intended by 224 in creating a model ACO program is that it would be adopted by at least the state purchasing members through the Group Insurance Commission, the connector, incentivizing their plans as well as MassHealth. Obviously, we've had this very strong relationship with MassHealth to date, but I think if we really do move toward an outcome-oriented distinction program, I perhaps naively think that will be of more value to payers in terms of product design, in terms of transparency efforts to members, and in terms of their own value-based contracting strategy. But until we try it, and I think try having a party.
So I think, looking at the timeline and next steps, I think the stakeholder engagement here is going to be critical, and you've obviously built that in, but I think it's really incumbent on folks to weigh in on these suggestions and get as much feedback as we possibly can.
So everyone comfortable with putting it out for public comment? Great. So just quick question, Marty. We got about 10 minutes start late. Do you want to go 10 minutes? I know Lauren, you have a hard stop at 12:30.
Why don't we keep going?
So I'll ask Adrian Anderson, our Senior Policy Associate, and David Arbach, to come We'll do an abbreviated version of this presentation, really just kind of showing some of the data and findings, and then perhaps have a more robust policy discussion at the next meeting. So Adrian, if you wouldn't mind, kind of quick introduction, because you have all the power over there. So as Marty said at the beginning of this meeting, a recent law, actually the second of the 3 opioid laws, so this was the middle one, charged the HPC with assessing access to providers that provide care for co-occurring disorder or dual diagnosis patients. Those are patients that have both mental health and substance use disorder conditions. And there were 3 main parts of this charge to the HPC. One was creating an inventory of who these providers are. The second was assessing the access issues. We accomplished that by issuing a survey, and those are the findings that we'll show to you today. And the last is the policy piece, which is, we found these access issues, we understand where these providers are. What would we recommend to the legislature in terms of addressing these findings? So I think, Adrian, just for the sake of time, maybe we'll skip the next 2, and then we'll start with slide 35.
And before you get into this, hi. I appreciate Commissioner Cohen going a little bit extra time, but I do know that there are members, staff members of the legislature who came to this meeting to hear this presentation. This was a legislative mandate and a really important one that a lot of members of the legislature and the administration care a lot about. So I do want to say we're probably going to skip over some of the slides here today, but want to offer to those in the audience an opportunity to follow up with us for a more in-depth discussion on these findings. And we really do want to hear from different stakeholders on these findings. This is not the final report. This is kind of the findings that will inform the final report. So it is an opportune time to weigh in with us. I just wanted to mention that as we kind of do have to move so quickly, but I appreciate a little bit extra time.
Thank you both. All right. I also will acknowledge Carol Jarina, who couldn't be here today, but was a significant contributor to this work, and will certainly be a major part of any conversations we have with stakeholders in the near future. So, all right, I'll start with this slide here, which is reflecting that in 2016, co-occurring mental health and substance use disorders were identified in 6% of combined inpatient and ED visits. This is, again, SHIA hospital discharge data. ED on the left and inpatient on the right. For the sake of time, I'm going to zip through these really quickly. This is sort of the theory behind the importance of integrating mental health and substance use disorder treatment, knowing that the presence of one can confound the other, and the severity and acuity of both is important to consider in both integrating care, making care coordination, sort of making investments in care coordination, being mindful of the prevalence of dual diagnosis. All right, here is a visual representing the organizations of licensure for both facilities and individual professionals within the behavioral health space, particularly relevant to dual diagnosis here, co-occurring disorders. Excluded from here are public health hospitals, VA care, some other important settings of care, but just have that for questions.
Yeah, I was remiss in saying that the Department of Mental Health and the Department of Public Health are really important partners to us in this work, and we have consulted with them throughout the survey development and the findings, and will in terms of the policy. I do know that the administration and Secretary of Secretary's office is really committed to addressing the licensure complexity, for lack of a better term. And I don't know, Lauren, if you want to spend a moment on that.
I would say that this is certainly kind of addressing this population is certainly a priority. The Secretary has kind of convened a swap, if you will, of the relevant agencies to really take a hard look at behavioral health services and the access issue. And so kind of related, I don't want to kind of jump ahead to some of the findings, but I think there are some immediate next steps that we are taking to address many of the issues that are highlighted in some of your preliminary findings around streamlining and updating, looking at regs, particularly around clinics, to help increase access we're looking at, DPH put out a procurement this past October to solicit providers to meet the needs through residential rehabilitation services and co-occurring enhanced programs to really draw in providers to do this type of work for this specific population. And then there are other efforts around workforce that we are pursuing to encourage medical schools to include in the curriculum treatment for substance use disorders. So those are just kind of a couple of things that are hot on our radar, and I think we, as you said, this is a really big priority for the Secretary of the Administration.
Great, thanks, that's great, thank you.
Great, thanks so much. All right, so this slide here represents the 575 licensed clinics for different types of behavioral health outpatient services, both substance use disorder and medication, as well as counseling. But we'll revisit this later when we talk about the survey response. This is a work in progress map, as is this one. If you have them printed out, they'll sort of be a useful pair. But the first is the broad landscape of duly licensed provider sites throughout the Commonwealth. The next one uses those site locations to map the percent of the population over the age of 18 who live 5 or more miles from the nearest duly licensed clinic. And so this is being updated just to reflect the very most recent licensed data, and will serve as part of the inventory that Katie mentioned was a component of our legislative mandate. All right. So the survey methods themselves here involved combining data from commercial payers, provider directories, SAMHSA data, data from DMH and bureaus within DPH. We also cross-reference those files with address and site name to identify the number of sites and make sure that we're accounting for everyone. We contracted then with a vendor to create and administer a survey, which asked many questions, involved complicated sort of skip logic and branch logic, so we don't have all the questions listed, but the high-level description of what those questions sort of tried to probe is listed in the slides. And we had responses from 405 sites of service, which represents more than 50% of behavioral health treatment sites at any level of care in the Commonwealth. So we're very pleased with that outcome. I won't touch on it now for the sake of time, but we did also receive 170 responses from individual clinicians in active practice who represent an important part of the commercial payer behavioral health care landscape. These are just the questions I alluded to as being core to the survey. So results themselves bucket into these 4 categories here, which when we eventually have policy recommendation conversations, these themes will again be reiterated. I'll jump right into the findings themselves. So nearly 60% of providers report offering both mental health and substance use disorder services as primary treatment. However, dual licensure is still fairly uncommon. So you have on the left the same graph we saw earlier of licensed clinic by type of license, and that's the NS 575 I showed a few slides ago, where mental health clinics represent about half, duly licensed 1/4. And on the right, you see our survey respondents. There's some probably sampling bias on the right-hand side, which would explain some of the differentiation between the size of the yellow portions in each graph, but that still doesn't explain away the difference we're observing here, suggesting that more sites provide dual services than are technically licensed or would put themselves out to be or identify as being providers of dual diagnosis care. So providers, this is an interesting finding, I think, related to vulnerable populations. So here we observed in particular, at least from the survey respondents' point of view, that patients who are deaf or hard of hearing have had a history of judicial involvement and are between 16 and 25 years old, in some parlance known as transitional age youth, represent populations with particularly difficult access or limited access to care for co-occurring disorders at respondent sites.
I think it's just important to reiterate here, this is provider-reported data. So I think, a reasonable person could assume that any patient-reported data might have more access issues, but if the provider themselves are reporting that they're not able to serve people who have justice involvement or are at a transitional youth or deaf or hard of hearing, that's a problem.
All right, so here we're looking at prescribing and medication arrangements. Bit of a complex graph, but I'll explain here. So the N is 98, so these may appear to be percentiles. It's just a coincidentally similar N. So on the left, you have substance use disorder prescribing, and on the right, mental health prescribing. And what I'd like to highlight here, and for the sake of time, is that the red columns in each represent provider sites for whom there is no arrangement, no formal arrangement or informal arrangement for prescribing. And since we know prescribing to be an evidence-based form of treatment, both for mental health and substance use disorders, this is worthy of additional consideration and policy recommendation exploration as well. All right, here is one of the particularly compelling findings, again, toward policy recommendations, especially in the workforce domain. On the left, access for adults who do speak English. On the right, for those who do not. You see incredible disparities going up through the 5 to 8 week period. So really focused in the walk-in, same-day, open access sort of innovative scheduling we're seeing a bit more and more of, but still significant disparity here, end of the 2 weeks or less groups. All right. This is for wait times to medication for addiction treatment. Blue representing methadone, orange buprenorphine, and yellow naltrexone. Again, to reiterate, these are survey responses, so this doesn't represent the full picture of medication for addiction treatment provision in the state, in the Commonwealth, but it does suggest that there's a broader range, at least of these respondents, for those who prescribe buprenorphine going into the 5 weeks on the right here. All right, our last data findings slide is related to training on co-occurring disorders. So we did not probe with any sort of particular parameters on what training would involve, but it might be things we expect that it would be awareness of how to identify and respond to the presence of the disorder, which is not sort of the primary identity of that provider site. And so staff with basic training broke out this way, so that 56% of our respondents had more than 75% of their staff trained, but the breakdown here, with even some representing fewer than a quarter or none of their staff trained in co-occurring disorders, is an area for improvement, certainly. Okay.
So thank you for going through those very quickly. As Adrian said and David said, we have more data on this. We're happy to talk to anyone one-on-one about it. We're really excited about the data and really excited about having a broader discussion about what the policy implications of this work are. We teed up 4 possible areas of policy recommendations. Again, in light of the administration's commitments to the licensure issues, I think perhaps we could spend a little bit more time in the workforce or in integrated care models, and we mean that both integration between mental health and substance use disorder and behavioral health and physical health. So two meanings of the word integration. And then finally, sort of the never-ending issues around, can you bill for a mental health visit and a substance use disorder visit in the same day or not? So some like really complicated and confounding structural problems to providing integrated care for this really vulnerable population. So we'd love any thoughts or comments from commissioners at this point.
Chris, I'll start with you. Any comments? Absolutely. So I think this is really compelling work in an area that has deserves a lot of attention. I mean, this has been an area that has been siloed way too long, and your charts show that clearly. I know I work in Framingham. I hear every day the weight that people who don't speak English experience waiting for outpatient mental health and substance abuse treatment, and the lack of clinicians who are linguistically and culturally appropriate but have the right certification to be able to treat. So I think workforce is where it's at. I think these others, I'm happy to hear Lauren speak of licensing and regulation work. I think that's long overdue and obviously relates to the workforce. The integrated care models, I mean, we're seeing progress, slow, but we're seeing progress, but the workforce is, I think, what's really holding us back on the access issue. So we'll just reinforce that as an important area for consideration. But full speed ahead.
Thank you very much.
Yeah, and I would just, add one bit of color commentary here. We engaged with an expert external agency to do, a pretty robust survey, because there is not the data that exists to be able to identify these sites in one place. So we had to go out and ask 400 different providers, and the survey itself was over 400 pages if you actually printed it out. This was a huge effort just to try to get some of this information. And think if you're a patient or a family member who's trying to navigate this system. So I do think, one of the findings from even engaging in this work is how difficult it was to even begin to identify where those locations are, what services they're providing, what their relationships are to be able to do prescription management, what the training at some of these sites are. And the fact is that the very small number of, only a quarter of these are being duly licensed. But there's a lot of providers out there who are reporting to us that they are providing services in both areas. And what are those services? What is the right type of oversight involved here? So I do think, even engaging in the work of doing this survey, I think highlights how complicated and opaque this particular intersection of these two healthcare needs is, and I think, is a call for action.
Absolutely.
Thank you. I have just 2 quick slides teeing up a vote that will be at the board meeting on the evaluation for our investment program that is trialing medication for addiction treatment in the ED. And so this is just some background for Dr. Kreider and Marty to take a look at before the board meeting, but we will be talking to you before then as well.
Great. Looking forward to it. I talked about having a party and no one coming. I better be careful. Well, if there's nothing else, Chris, anything else you want to add before we adjourn? All right, take care. Thank you all.
Thank you.